Welcome to the ASN Kidney 360 podcast. I am Claretha Lyas, Assistant Professor in the Division of Nephrology at the University of Alabama School of Medicine and Director of the Chronic Kidney Disease Clinic. I am joined by my colleague, Dr. Denise Thornley Brown, Professor Emerita of the Division of Nephrology at the UAB School of Medicine. Today we will discuss my perspective article entitled A Call to Action for Addressing Disparities and Increasing Diversity in Academic Nephrology, published in Kidney 360 this March. Thank you, Dr. Brown, for joining me today on this podcast.
Well, thank you, Dr. Lyas. It's a pleasure to be with you. What are some examples of systemic racism in U.S. society?
In many ways, racism in the United States has transformed from overt displays of discrimination to more covert and insidious methods. During the Jim Crow era in America, a set of state and local laws in the southern United States enforced segregation. Many of these laws were eventually reversed by the 1970s. However, now many policies are in place that continue the spirit of segregation, but in more discrete ways that span all aspects of our society, to include education, employment, housing, credit markets and wealth generation, the justice system, and healthcare. In the perspective article, I cite segregated housing exists, leading to worse health outcomes and chronic disease, as well as lower performing public schools, due in part from a smaller tax base. Segregated housing owes its history to the 1933 Homeowners Loan Corporation Program, which was established as a part of the recovery package from the Great Depression. This legislation designated communities with largely populations of color as unwise investments for home ownership and made it more difficult for African Americans to receive home loans. Although this practice eventually ended with the Fair Housing Act of 1968, the effects of it still ring true today, with many neighborhoods remaining segregated and having property values much lower than those of primarily majority communities. Similar discrimination can be seen in healthcare, where both unequal access and unequal quality of care exist for minorities of color. In nephrology specifically, there are often delays in referral as well as unequal access to transplantation.
Can you describe some examples of racism that you encountered personally in academic medicine?
Sure. The racism I experienced in medical school, fellow training, and as a faculty member was never overt racism, but it was always insidious and what many would term as microaggressions. While I was a medical student, my attending gave my senior resident, who was an African American female, and I feedback about our clinical performance during the rotation. He started the conversation by going into detail the genius of one of his other male colleagues who trained with him and how remarkable it was that this colleague could remember and articulate the most minute detail. As my attending described, it was only people like this smart male colleague who were truly smart in the world, and my senior resident and I were not like him. Therefore, we were not smart. As I continued through residency, I remember a white male patient making an inappropriate comment after seeing a group of African American hospital workers in the hallway. He stated, "I didn't expect to see an assembly of an NAACP meeting in the hospital," referring to the laughter the African American staff members enjoyed in the hallway. Other examples I have experienced are similar to those of other African American medicine faculty. For instance, many patients refer to me as the nurse. Also, there was a time while I was on rounds, one patient refused to make eye contact with me and wanted only to talk to the male white resident instead of to me. When I decided to wear my hair as a natural afro a few years ago, an older white patient asked me what was wrong with my hair, as if this was an inappropriate hairstyle.
What changes should be implemented in academic medicine in order to increase the focus on racial disparities in medicine?
Racial disparities exist not only in chronic disease and health outcomes, but also in academic medical institutions. There are few minorities of color represented in academic faculty and even fewer as leaders in academic institutions. One way to increase the focus on racial disparities is to acknowledge that it exists, that it has been a problem for decades, and that it deserves a solution. This will involve changes in practice patterns and addressing the conscious and unconscious bias in medical practice and in medical training of students and residents. Racial bias is now receiving the much needed attention that it deserves. In a recent article in the New England Journal of Medicine, a 2016 study was highlighted that showed nearly 50% of white medical students and residents believe there are intrinsic biological differences between blacks and whites. Also, in another New England Journal article, the bias in medical care was showcased with the story of the death of Dr. Susan Moore, the African American physician who died from COVID. Prior to her death, she was able to chronicle through social media her medical care experience of not being heard and devalued as an African American. Unfortunately, her story is not rare. Stories like hers can be told of many African Americans over the past several decades. Within the past year, I heard such a story from an African American female dialysis patient with metastatic pancreatic cancer, who described to me the vague abdominal pain and nausea she experienced for more than a year. She says that her symptoms were dismissed by every physician she explained it to, while only later receiving the diagnosis of metastatic pancreatic cancer incidentally after a CT scan was done for another reason. Therefore, placing a focus on racial bias and working to effectively address it will make a huge impact on racial disparities in academic medicine.
What measures do you recommend to improve recruitment and retention of faculty of color?
In the Perspective article, I make a number of suggestions that could improve faculty of color recruitment and retention. First, I believe there should be a declaration to substantially increase the number of faculty of color in academia over the next 5 to 10 years. The recruitment efforts will need to be intentional and may require that faculty of color are considered along with white faculty for all available positions within an institution. Once faculty are recruited, there will need to be long-term changes for retention. This will require effective mentorship, increased allocation of resources for faculty development, and assurances that there will be an equal access to opportunities needed for promotion and tenure. In addition, academic institutions can highlight their progress and commitment to diversity by showcasing their diverse faculty in media campaigns, making it known that their institution cares about diversity not only by the words they speak, but also by the actions they do. So in conclusion, systemic racism continues to exist in our society and in our academic institutions. It is often covert and it manifests as unconscious bias. Comprehensive measures are needed to address it by first acknowledging its existence and then making deliberate steps to eradicate it. Thank you for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.